Hello, everybody. Good evening, and welcome to the third series of the Advanced PFT workshop. And in today's session, we are on the cardiopulmonary exercise test series. It is in the under the joint banner of Indian Chest Society and supported by PACS India. To introduce myself, I am Dr. Indranil Halder. I am the associate professor and head of College of Medicine and JNM Hospital, and I am also the East Zone chairperson of Indian Chest Society. So, as all of us know, our speaker for today's session is Dr. Deepak Talwar, and practically he needs no introduction in that way, because everyone, starting from the senior, the junior, knows about him. He's a doyen in the field of pulmonology, and my association started long back when I was really fascinated in hearing his lectures in different national conferences. I have seen or attended his attended his lecture not only in national conferences but also in some of remote places like Bardhaman. He has gone to Bardhaman to give his lecture. That's the real beauty of him. He is a dedicated and a great teacher, I tell you. He is really a good clinician, and he is really innovative researcher and has a lot of publication in his name. But the real thing is, he is really enthusiastic. He has brilliant, eloquent, and spellbinding, impressive oration. That's the beauty of him. And for those who don't know him, practically to introduce officially, he is the senior consultant and chairman of the Metro Center of Respiratory Disease in NRC Noida. And in the last 22 years, he has been in the position of the director and chair at the Metro Center for Respiratory Disease, which is the state-of-the-art facility for pulmonary medicine in India. Most of pulmonologists probably have heard of it. He has also been the DNB in charge for respiratory disease for the past 12 years, and from where about more than 42 postgraduates have enrolled, and he is the most sought after place for the DNB students also. A lot of publications, as I told, more than 82 original research articles in international and national journal. And in fact, I am to tell that his topic on hypersensitive pneumonitis and management of difficult asthma is really worth reading it. He is a good teacher, researcher, clinician, and he has been associated with a lot of very renowned institutes, of to name the BPCHES, the RML Hospital, and most important, the PGIME at Chandigarh, the MAMC, and the LNJPM Hospital. So with this, I'll be handing over to Dr. Talwar to proceed the session. So before I start again, just to have some of the housekeeping, and it will be a real interactive topic. There will be a lot of question answers in the end, and we'll be having, to make it more interactive, what Deepak has done, there are some polling session. I'll be requesting everyone to poll, because we will know about the idea, what you know about this, and in what way the approach should be. So over to you, Deepak.
Thank you, Indranil. Thank you very much for a very, I think more than what I deserve in the introduction which you have given me. I thank you from my heart, and I am very happy to have learned people to be with me on this advanced lung function test and on CPET Basics. Indranil, you have accepted so happily on this topic, which shows your commitment to not only utilize the things or learn more in pulmonary medicine, but also go into the areas which are little, what we call is, out of the comfort zone. I think that's the word which I would use, out of the comfort zone. And I think CPET is definitely one of the area which is out of the comfort zone for the pulmonologist, because this is a real hard time test. And considering that the utility of it is primarily grossly underutilized, with one of the major reasons is that we all feel it is a very complex thing. So we are going to cover the basics of it today, and of course on the equipment and how to use it and how to use it in cases will be on the next next module, which is going to be the last of the series. But today is basically to understand what is this and how to go about it, and then to make an understanding of the whole process of exercise testing, which you can utilize it to make a interpretation of the results of the exercise testing. That's what the aim is. So we go with the various questions, and the first question has already come on it, and all the questions are going to be dealt by Indranil, and Indranil has really agreed that he will rather throw a light on the question and why the question has come, and then he'll give us the answers. And from
true to that, because many of the medical colleges, government medical colleges, do not have a CPET, or it is there in the department of some other department. Try it, but too complicated to understand. Some may think that it is not for pulmonologists, it is the cardiologist domain. And in fact, I will be true to that. After hearing Deepak's lecture, probably most of them should be convinced in doing it, and whether you are interested but don't know how to use it. A real, honest answer, and your polling starts now. So, in fact, 4, 3, 2. Majority of them are interested. It is about 60% of these attendees are telling that they are really interested but don't know how to use it. Only 31% told that they tried but too complicated to understand. A few 5% in 1 and 3. So never, at least 5%, at least for those, you will do justice, I think so, Deepak. So what do you, Deepak?
Oh, I think, Indranil, this is a wonderful case, wonderful mix today. And there are people who are interested but do not know how to use it. There are people who find it too complicated to understand. And of course, these are the two domains which are 90%, and I need to address this actually. So if at the end of the day, I am able to do and justify these two groups to make them realize that it's not that complicated and it is not that difficult to understand and difficult to use it. The only situation is that once you get used to it, you will really love to see it, that how you can solve the puzzles which you all come across as a pulmonologist in your practice. And that's what the idea is, which I'm going to discuss with you today. So CPET is, of course, it's like cardiopulmonary exercise testing. The term itself, has got a little lengthy domain, but it's considered as a mixture of art and science. So science is something which is, is not easy to understand, and art is something which you need to acquire. So obviously these two combination of CPET is itself very difficult, and I won't blame anyone that if they feel that they really are interested because they want to know what it is, but they find it too complicated to understand that. And that's exactly what my job is going to be today. And you can see this, that I start with basically, that you need to understand when you are put to exercise, what are you doing? So you can see in the cartoon very well that you are trying to, whether you do walk or you do a bicycle or any kind of exercise, you start using your muscle. So it is trying to show you that the muscle activity starts by contraction, and muscle needs to get the energy to do that. Now, how is that energy going to be supplied? And that's the entire process which we are going to see. And what we see here is that the muscle which are actually contracting, the oxygen supply which is required for the metabolism which happens in the muscles is to be supplied from the respiratory system. So the oxygen has to be brought into the body by the respiratory system. Heart has to carry it into the circulation, which will take it into the muscle. And finally, it will be the job of the muscle that it takes it inside, that oxygen, to the mitochondria, and these mitochondria are going to utilize it for conversion into the pathways which are utilizing glucose till the time glucose is available, and production of the ATPs, which will be required for the contraction of the muscle. So simply what we are trying to do is, we are trying to look at it that if a person is doing exercise and he stops the exercise, because he is not able to do it, what is the issue which is wrong with him? Is it his muscles who are not able to do this contraction or able to carry out with this work? Two, is it because of his respiratory system, which is not able to provide the oxygen which is required constantly for these exercising muscles? Is it the heart, which is not able to take the oxygen from the lungs but pass it on to the circulatory system, which is going to carry it to the muscle? Or it is the circulation, which is compromised and not taking the blood, which is oxygenated enough by the lungs and the heart to the muscle so that the muscles can utilize that oxygen to produce the energy. So it is a complex mechanism by which a contracting muscle or the work which we perform or the exercise which we do will require a complete coordination of the respiratory system, of the cardiac system, of the circulatory system, and finally the muscular system. So these are the four different systems which are put into work when we start doing the exercise. So it is not the muscle only. Every other three systems which I have told you are equally responsible to constantly supply the oxygen so that the muscle keeps on doing the exercise. And at one point of time, it will not be possible for the respiratory system, the cardiac system, the circulatory system to constantly provide the oxygen there, where the muscular system will not be able to sustain that activity and will fail you by telling you that I cannot do any more exercise. That's the normal way it happens. And when we try to do it in the disease states, what we are trying to determine it, that what was that factor which led to this stoppage of this exercise which the patient has started doing? Was it the muscles? Was it the lungs? Was it the heart? Or is it the circulatory system? That's the entire gamut of the exercise testing which we'll try to utilize in clinical practice. So muscle, respiratory and cardiac. Of course, the circulatory in between comes, but these three are the most important pillars of the exercise testing, which is trying to identify what is the limiting factor for the exercise. We do certain exercise tests like 6-minute walk test, which has been already discussed in one of the seminars of the ICS. And they are like, the tests which are done as per the patient's own effort, his own pace, his own time, and it is defined by the 6 minutes. But when we talk about cardiopulmonary exercise testing, it is very important to understand it is an exercise to the limitation. So what it means is you are supposed to do the exercise till you are not able to do it anymore. And then it is the job of the pulmonologist or the person who's performing this cardiopulmonary exercise test and interpreting it, that what led to this limitation. Is it a normal limitation or it is an abnormal limitation? If it is an abnormal limitation, is it because of heart? Is it because of lungs? Or is it because of the muscular factors? That's the entire process of exercise response which we try to monitor throughout this exercise testing which we do, whereby we try to define that what has led to limitation of an exercise to an individual person. Simple example is that a person says, and he says, I can't walk more than 500 yards. So that is what we are trying to define, decrease in exercise capacity. So we put him on to exercise testing. And then we let him do the exercise. We know that how much exercise this gentleman is supposed to do. If he stops at 50% and says, I can't do anything more, that means he's exercise limited and the exercise capacity is reduced. And now our job is that at that point of time, when he stopped it exercise, what led to the limitation or stoppage? Is it because the lungs were not able to supply the oxygen? Is it because the heart was not able to pump the blood? Or is it because the muscles got fatigued and were not able to carry on the exercise any further? And if you know the three different components, you will be able to decide the therapeutic intervention is towards the lungs, is it towards the heart, or is it towards the muscle? We presume that any patient who is a respiratory patient will be limited by the exercise just because he's got a respiratory disease and the lungs will be the limiting factor. But that need not happen. They may have other limiting factors for the exercise rather than their lungs. So that's what the test is going to tell us in detail. So you can see that to understand, once you start doing exercises, what are the normal responses and what would be considered as the abnormal responses, we need to go through this entire process of exercise, which is basically, you can see that down here there is a gentleman who started walking, or it could be even cycling, any of the ways, and it requires more oxygen, which is going to be supplied by the lungs, carried by the heart, going via the gas exchange, ultimately into the circulation to reach into the exercising muscles. And how do they respond? That's the next question. And these are what are called as Wassermann gears. So what it means is that when this exercise starts, it is basically production of the energy, which is at the level of mitochondria, which uses oxygen and leads to production of carbon dioxide by the glycolytic pathway. We know that. There is a glucose in the muscle. Glucose is going to be metabolized by the glycolytic pathway, aerobic pathway, which will lead to production of ATPs. And in that process, ATPs will be used by the mitochondria to produce the muscular contraction. And the oxygen which is going to be consumed is going to be supplied by the blood supply, which is coming to the muscle. And in turn, the carbon dioxide which is going to be produced is going to be sent to the venous side, which is going to be taken to the heart and finally being delivered into the lungs, from where it is going to be exhaled out. So carbon dioxide is going to be exhaled out by the production of energy in the level of mitochondria by the glycolytic pathways, by looking at the glucose, where this the breakdown will occur into production of ATP and production of CO2. On the other hand, to constantly supply more and more oxygen so that the patient is able to, or the person is able to continuously do exercise, the oxygen levels have to be supplemented from the lungs by increasing the oxygen intake, which will be taken by the lungs, and after the gas exchange will be passed on to the heart. And after the heart improves its cardiac output more and more to accommodate this increased oxygen to be carried to the tissues, so that the tissues are able to produce more and more exercise. So this is the entire gears which needs to work in a proper fashion, so that the end product is the production of the ATPs by the glycolytic pathways, which requires oxygen in the mitochondria of the muscular system. So that's the whole process. If it doesn't work in a perfect gear fashion, then it will lead into the limiting factor, which can be at A, which can be at B, or which can be C. And you can see that A is the lungs, B is the heart, and C is the muscle itself. So that brings us to question number 2, and I hand over to Indranil.
Yes, Deepak. So what we understood is that CPET is a global test of patient's cardiorespiratory capacity, since it reflects the entire oxygen transport system, beginning to the lungs and ending with the skeletal muscle. So with this, what the question is, what is the respiratory response? We'll come to the other responses also. What is the respiratory response to exercise in healthy? Increase in minute ventilation. Number 2, whether it is tidal volume increase to vital capacity, increase in the dead space ventilation, or increase in VQ inhomogeneity. So you should start your polling.
So only one answer is correct.
Yes, one answer.
So what happens to the respiratory system when you start exercising? So I think if you think of it that you have started running, what happens to the respiratory system, you will immediately understand that.
So Deepak, it's very strange that 88% of them voted, that all of them practically voted for increase in the minute ventilation, 88%, and only 8% tidal volume increase to vital capacity.
I think that's a wonderful answer.
Wonderful answer. So really, that means
answer.
People have done their homework.
They have done their homework. They already know about it. They want to build up more knowledge on it, and that justifies you and me both sitting here for 2 hours today and taking this talk for.
Deepak, it's true that for any workshop, if the PGTs, in fact, my PGTs, I've told them that its homework is to your topic before you come to the workshop. That's the most important thing. At least you'll be ready with the questions or understand it in a better way.
Absolutely. I think wonderful that you start running and you start panting. So in running, what is happening is you are increasing your rate, you are increasing your tidal volume, and ultimately the product of tidal volume and respiratory rate is the minute ventilation. So the moment you start your exercise, you start increasing the ventilation. In fact, before you even start the exercise, you even think about it that you are going to do an exercise, some amount of increase in tidal volume and respiratory rate will occur in minute. And this is a graph which visually is trying to tell you beautifully that what happens to the individual parameters. So you can say immediately the first thing which happens is a huge increase in tidal volume, then there is an increase in respiratory rate, and then there is a difference. There is a difference in a way that the tidal volume keeps on increasing till the time it cannot increase anymore. So you can imagine that, you cannot go to a tidal volume to such a level that you can go up to the total lung capacity. It does not happen actually. You can maximally reach up to 70% of your inspiratory capacity, because you can see that if you start breathing the tidal volume to your total lung capacity, you won't be able to sustain it. It will just go away in 2 to 3 breaths. So ultimately you settle down to a level where your tidal volume is almost about 70% of the inspiratory capacity or 50 to 60% of your vital capacity. And at that level, the only thing which can increase further minute ventilation is you can see the respiratory rate. So respiratory rate slowly starts increasing and keeps on increasing, keeps on increasing. Finally, at that point when the tidal volume cannot increase any further, it's only the respiratory rate which is able to do. But then after reaching about 50 to 55, you can't even increase your respiratory rate. So what happens is that's the ceiling that minute ventilation can increase, where tidal volume has reached maximum and the respiratory rate has become maximum. So in a normal human being, when they do an exercise, they can achieve a big increase in tidal volume. It can go, as I said, that about 60 to 70% of vital capacity and up to 50 to 55 of the respiratory rate. But with training, you can increase your tidal volume more. You can go another 10% extra, and that's what the athletes would do. They will try to increase their tidal volume more than what they can, so that they can sustain it for a long period of time for the sustainable exercise testing which they can do. So they can train and improve that. But yes, everybody is right that if you have to give more oxygen to the muscle, you need to take more oxygen inside. And the only way you can take more oxygen inside is by increasing your minute ventilation. All of you are correct, absolutely. Dead space cannot increase. If you increase the dead space, it will be wasted ventilation. In fact, the ventilation should improve. And in such a way, it should improve, the dead space should decrease. Similarly, VQ mismatch should improve. All those areas which were previously not ventilated, all those areas which were previously poorly perfused will now be more active during exercise, so that the VQ mismatch will improve, so that you are able to carry on more oxygen. So the entire respiratory system will now try in a way that more oxygen which you are bringing in by increasing your minute ventilation should be transferred across the gas capillary membrane, which is our alveolar capillary membrane, into the pulmonary circulation, where it can be carried on to the heart, and heart should be able to pump it into the muscles by the circulation. So that's the idea. The more oxygen required by the muscle, it has to be provided by the respiratory system. We know that there are other processes which are going to happen on the way, and that's the next part which we are going to discuss about the cardiac responses. Over to you, Indranil.
So after the respiratory response, now it comes to the cardiac response. So what cardiac response seen with exercise in healthy? Is it increase in the cardiac output? Is it decrease in AV oxygen extraction? Is it steep heart rate response or plateau at peak oxygen pulse? So please poll now, please. So the result shows 78% votes on increase in cardiac output and only 22% on decrease in AV oxygen extraction. Again, the same trend of results.
Absolutely.
So
Absolutely.
what do you, Deepak? So how you should?
Another good response from the audience that now to match the increased minute ventilation from the respiratory system, you need to increase the cardiac output from the cardiovascular system. So that's, I think, very simple thing. As we are increasing the minute ventilation, we are going to increase the cardiac output. Now we have seen that when we are talking about minute ventilation, we could increase the tidal volume, we could increase the respiratory rate. So in the cardiac system, in the cardiac output, we know it is stroke volume into heart rate. So we will increase the heart rate and we'll increase the stroke volume. And as the exercise intensity increases, you can see that there is a tremendous increase in the stroke volume and there is slowly increase in the heart rate. This is just in parallel to what we have seen in the respiratory system. The tidal volume increases and the respiratory rate slowly increases and keeps on increases. You can see the slope of the curves. The stroke volume immediately starts increasing and then the heart rate also keeps on increasing till the time heart rate achieves its maximum. And that is the point where you will be generally stopping it, because heart rate will not achieve, it won't be reaching a level where you can say that it will plateau, but the stroke volume will plateau. After one time you will realize that the stroke volume cannot increase any further, because otherwise the end diastolic volume will have no blood to pump it out actually. And then it is also dependent also into the amount of oxygen which is being carried into the arteriovenous system, which is the ultimately what we are talking about is the extraction. And you can see that even the extraction by the muscle which is doing will be able to be doing much more with the exercise till the time the maximum oxygen which they can take from that arterial content, arterial oxygenation or oxygenated blood is the maximum, and after that they will not be able to do it more. So not only the heart is able to provide more oxygen which the lungs have given it by increasing their stroke volume and the heart rate, but also the last part is the muscular part, and in the muscle they will try to extract more oxygen. Whatever has come to them, like a hungry person, they will try to take extra also from there. So now you can see that the process is that the oxygen is more from the air getting into the lungs, and lungs passing it on to the heart is passing it on to the muscle, and muscle is taking it along with even extracting more from whatever is in the blood available. So you can see that this cardiac output, you can see that the cardiac output is completely increasing all the time. You can see that. And then the heart rate and oxygen pulse, this is called oxygen pulse, which is VO2 over heart rate. So VO2 is what? VO2 is the maximal oxygen uptake. So maximal oxygen uptake is what we are trying to look at it from the muscular perspective, and it is going to be provided by the lungs. So VO2 in a minute, or the maximum oxygen uptake which is going to be taken in 1 minute from the from the lungs, is something which is going to be supplied to the oxygen. So this is the primary measure which we are going to look at it, that is the oxygen uptake which is happening in an individual person who's doing an exercise. So oxygen uptake, which is normally we know about, is 250 ml per minute. It is going to increase tremendously with the exercise, and if it is not able to meet that what is required from the exercise, the person is going to be limited in the exercise. They won't be able to perform that exercise, because this oxygen has to increase proportionate to the exercise. So the more exercise you are doing, more VO2 is to be supplied, till a point will come when the body will not be able to supply that. And that's the limitation which we are going to see, whether it comes normal or it comes abnormally. If it comes abnormally, that means it's going to be low. And if it is going to be low, then we are going to see that who was not able to take the oxygen to the muscle, the lungs, the heart, the circulation, or the muscle itself. That's what the idea of doing this cardiopulmonary exercise testing is, to the point of what is called as limitation. And that brings us to the fourth question, and over to you, Indranil.
So beautifully explained, Deepak. So the next again, what circulatory response is seen with exercise in health? Is it the increase in the systolic pressure, increase in the diastolic pressure, or increase in the mean arterial pressure, or increase in the peripheral vascular resistance? So the poll starts now. And in fact, here we have a mixed response. Practically 50% of them are increase in mean arterial pressure, that is answer C that they have given. 3, 25% each in increase in systolic pressure and increase in the peripheral vascular resistance. So here we have a mixed result. In fact, if they're asked to select one answer, this is what happens, Deepak. In fact,
obviously, then it is little confusing, and I perfectly agree. Now you try to understand that the increased amount of cardiac output, which is coming from the heart, has to be accommodated by the circulatory system so that it is able to take that huge amount of increased blood flow smoothly to the muscle. So the pressures have to increase. Systolic pressures will increase. But if the peripheral resistance increases, then the blood flow will not be there. So peripheral resistance has to fall. And if the peripheral resistance falls, the diastolic pressure will fall. So mean arterial pressure will remain the same, but it is the difference between the two which is going to match so that the increased blood flow is maintained, and fall in peripheral resistance will allow the smooth flow of blood from the heart into the muscle. So this is the third component of this exercise, which needs to be again coordinated so that whatever the blood, oxygenated blood is there with the heart, which is trying to pump it to the muscle, then the circulatory system or the conduits which are going to take it to the muscles must accommodate that large amount of blood flows which are coming, by making the pathway less resistant. And to make it less resistant, the pressure will rise definitely, but you need to decrease the vascular resistance. So that's exactly what happens when you look at the rest and the exercise changes which occur in patients, in people who are doing the exercise. You can see that the skeletal muscle blood flow increases hugely. Obviously, that is taking oxygen. So that is why the muscle will be able to do the exercise. Mean arterial pressure increases a little bit. Systolic arterial pressure increases tremendously. You can see 50% increase. However, you can see the straight line of the diastolic arterial pressure. It does not change at all. And this is primarily, you can maintain this because there is a significant fall of the peripheral resistance. So peripheral vascular resistance falls, and the increase in systemic arterial pressure is taken care by that. That's why the diastolic pressure does not increase at all. And you can see the cardiac output is about increase in 120%. So huge increases in cardiac output will be accommodated by fall in peripheral resistance as well as increase in systolic arterial pressure, so that it translates into almost 175% increase in the blood flow to the skeletal muscle, so that whatever oxygen has been taken by the respiratory system, finally it is able to deliver into the skeletal muscle. You can see increase in heart rate and increase in stroke volume. So you can see the heart rate increases much more in comparison to increase in the stroke volume, because we know that the stroke volume is dependent upon the filling. So if it increases too much, then obviously the filling will decrease and it will not be able to sustain it for a long time at all. So stroke volume increases about 30%, heart rate increases about 90%, and end diastolic ventricular volume only increases 10%, because if it increases, then there will be no flow. The stroke volume will fall down. So the end diastolic ventricular volume has to be maintained, and that's why there is hardly any difference. The ventricular filling is adequate and appropriate. And if it is not, then obviously the output of heart will decrease, cardiac output will fall, and patient will not be able to sustain the activity. So there are cardiac factors also in which the patient will not be able to sustain activity. There are circulatory factors which will not be able to sustain the activity if they are not, if they are abnormal. And same way there are ventilatory factors. So we have seen lungs, we have seen hearts, we have seen circulation, and then we move on to the last part, which is actually participating in the exercise, and that is the muscle.
So with this, after the lungs, the heart, the circulation, now comes the muscle, definitely. So the next question is, what is the muscle response is seen in exercise? Is it increase in aerobic metabolism to maximum, increase in anaerobic metabolism to maximum, progressive increase in lactic acid after starting exercise, progressive increase in the work efficiency? So you should poll right now. So the result, as it shows, is the 67% of them are voting for increase in aerobic metabolism to maximum, and only 33% increase in anaerobic metabolism to maximum. Okay.
So I think a lot of people have read about it and
So
understood about it.
that's what I'm telling them. Many of them has done their homework.
Absolutely, very well. I think fabulous that you know that when you start doing exercises and oxygen is being provided to the muscle, it will be aerobic metabolism. And when aerobic metabolism cannot be sustained because there is no more oxygen or the oxygen supply is becoming less and less with more and more exercise, then only the anaerobic metabolism will start. And anaerobic metabolism is not an efficient metabolism. We know that we get lots of ATPs on aerobic metabolism vis-a-vis a minor number of ATPs which come through the anaerobic metabolism, which we'll see over the next couple of slides. And of course, the lactic acid will only start coming in once there is a shift from aerobic to anaerobic. So if the anaerobic metabolism starts from the beginning, that should never happen. That means the blood flow is very bad to the muscle and it is not able to provide oxygen enough at all. So something is grossly wrong where anaerobic metabolism starts early. So that's also not possible. And I said that to progressive increase in work efficiency. So the work efficiency, you know, it is dependent upon the energy substrate which is there and its combination with the oxygen metabolic pathways and leads to development of ATP. So when you start, you have lots of ATPs. And when you go on, the number of ATPs coming is becoming less and less, and then finally getting into the aerobic, into anaerobic metabolism. So this is the energetics of exercise. I think this is little tough, but I would try to make it simple. That you can see that we start with aerobic metabolism and get into anaerobic metabolism, and the work efficiency keeps on decreasing from 50% to 25%, means that you are taking more oxygen and you are getting more energy initially, and later on you are using more oxygen and getting less energy because of anaerobic metabolism. So initially we start with carbohydrates, and as the carbohydrates are getting more and more, they are more efficient, and then finally we go on to fats, and then ultimately it is the anaerobic metabolism which yields much less energy in comparison to the oxygen which they consumed. And that is where the lactic acid starts accumulating in the blood. And lactic acid is something which will upset the entire energy balance and will try to limit the exercise to beyond which you cannot go, because more and more lactic acid stimulation, lactic acid in the blood will lead to development of fatigue factor. So you can see that the same gears, the lungs, the heart and the muscle, only thing is they are starting the other way. You can see that the oxygen getting in and then getting into the mitochondria and coming back as CO2 there. And you can see that the amount of changes which occur with exercise. So VO2 increases to 110 liters per minute. We know it's on resting about 4.5 to 5 liters. So huge increase. VCO2 released is almost about 120 liters. So more carbon dioxide than oxygen. That is because of the anaerobic metabolism. Anaerobic metabolism will produce more carbon dioxide, and it will ultimately lead to the excretion of more carbon dioxide. And of course, you can see that the heart factors, you can see the cardiac output increases to almost about 500 liters per minute. This also will depend upon the training effect of the person who's performing it. And of course, the muscle uses all this oxygen, which is coming almost about 450 liters per minute. So there is increase in VO2, which is achieved primarily by heart rate, stroke volume, and as well as the AV oxygen extraction by the muscle. All of them together will lead to much more increase in VO2 supply of the muscle rather than a single factor which would have been responsible. So if you find out if there is something wrong which is happening to VO2, it is that multiple factors which needs to be considered, which could be contributing to decrease in supply of VO2 to the exercising muscles. And that brings us to the question number 6, and over to you.
Yes, Deepak. So now it direct question. So as already discussed, we have seen the physiological changes, what happens in the lungs, the heart, the circulation, the muscle. Now coming to the measurement. So what is measured directly in CPET, whether it is the gas exchange, the cardiac output, the oxygen utilization, or the heart rate? So your question starts right now. Rolling. So yes, 85 of them answered it is oxygen utilization, and only 50% of them the gas exchange. Again, Deepak, so
Yeah. I think this is a complex mechanism actually, It measures so many things correctly. I think many answers may be correct here, but primarily in a cardiopulmonary exercise testing, what you are doing is that you are looking at the amount of oxygen gone in and the amount of carbon dioxide coming out. So where is it is happening? It is happening at a gas exchange level. So primarily in a normal healthy people, it will be looking at a gas exchange level. But yes, of course, if it is a limitation could be cardiac, could be respiratory, could be circulatory, could be gas exchange, could be even the muscular factors. So multiple causes could be there when it is a limited one, but primarily the limitation will be occurring at the gas exchange level. And this is what CPAT is. It has three transducers. One is looking at oxygen concentration. Second is looking at carbon dioxide concentration. And third is looking at the volume. So when you breathe in, breath by breath, it is taking how much of breath has gone in, how much was the oxygen in it, and when you exhaled out, how much was oxygen in it, how much was carbon dioxide in it, and the entire volume of it. So it gives you the amount of oxygen which has gone in, amount of carbon dioxide which has come out, and the amount of volume of air in which it happened. So you have a volume, you have oxygen, and you have carbon dioxide. There are only three transducers. So if you look at it, the volume, oxygen, and carbon dioxide, all these three factors are the determinants of the gas exchange actually. So that's why we say that it is primarily looking at it as a pulmonologist, breath by breath, the respiratory gas exchange which is occurring. The factors for that gas exchange could be many. It could be ventilation, it could be cardiac, it could be anything else, even circulatory and muscular, as I told you. But it is basically the difference of oxygen and carbon dioxide which we are looking at. So the principle of doing exercise testing is do the exercise test till there is a failure. So you need to get the response from the patient or the person who's doing the exercise test that I can't do anymore. I have to stop it. And at that point, when you stop it, you need to find out which of the physiological system fails. Is it the lungs who fail? Lungs normally should not fail at all. Is it the cardiac system which fails? Yes, the cardiac limitation is the most important thing in the normal healthy people. And it can improve tremendously with training. So that's what the athletes do. They improve their cardiac performance. So that's one which is the limiting factor. Or is it the muscle which is failing? So that is also trainable. So you can increase the muscular capacity. But generally, the muscular capacity will keep on taking oxygen because they can shift on from aerobic to anaerobic metabolism. So anaerobic metabolism can go on unless and until the circulatory system or the cardiovascular system, which is supplying the oxygen, says that it cannot do anything more. We know that heart rate cannot go beyond a level. We know that the stroke volume cannot go beyond a level. And we know that the extraction of oxygen by the muscle cannot go beyond a level. So that's the limiting factor. So cardiovascular limitation is the most important limiting factor which happens in normal people. And it can be trained and people can do more exercise by the training of the heart. Respiratory system never fails because it is ready to supply more and more oxygen. So in the exercise testing, we are trying to stress. It is the stress testing where the organ systems which contribute to the exercise intolerance to a level where they become so obvious that the patient says, I can't do anything more. So we need to profile that which organ system failed this patient that he could not perform more exercise test. Or if he performed a normal exercise test, then if he is able to perform that, then you know that there is no exercise limitation. So if the patient says there is exercise limitation and you find there is no exercise limitation on exercise test, then obviously you know that there are psychological factors and other factors which needs to be considered. It is not that the patient is exercise limited with a normal exercise test response where VO2 is achieved above 80%. That is what you need to do in your exercise test. That we'll see a little later. That brings us to another question.
Okay. So again, this is another important, very important question for CPET. So what is the central parameter for interpretation of exercise performance? Is it the maximum oxygen uptake, or as the VO2, the maximum heart rate achieved, that is the HR max, or the maximum ventilation achieved, that is VE, or the maximum work done, W max. So with this, please vote now. So the same trend now again, 88% have voted for the maximum oxygen uptake VO2 and only 12% in the maximum work done. So
in fact, all of them are correct. So it's nearly 100% correct answer.
The most appropriate answer, they have done it correctly.
Absolutely. I think Indranil, they have done more than the homework. I don't know why they goes on to the choice that it is difficult and complicated. They know it. VO2 max. So that's what we are looking for. The maximum amount of oxygen which you can take in is what is we are going to measure in CPET. That's the primary thing. And that amount of maximum oxygen taken, the only thing what we need to ensure is that the amount of work which is supposed to be done by that individual has been done appropriately or not, or adequately or not. So we decide on the basis of what we call as the work which an individual is to be done according to the height, weight, gender, all those things which gives us the norms to say that, you know, this much of work should be able to perform this person. And during that work, he has to get that VO2 value. So you can see that this is a chart which is VO2, that is the oxygen uptake, and this is the work rate. So as you start doing the exercise, you increase the work rate, the oxygen uptake keeps on increasing, and there's a linear relationship. And you can see the slope is 10 ml of VO2 per minute per watt. So that's the typical kind of a relationship which you get in normal healthy people. And this slope can become shallow when there is a inadequate either transportation or utilization of oxygen by the muscle. So anything which goes wrong will change the slope of this. So whether it is a disease of heart, is it a disease of lung, is it a disease of circulatory system, musculoskeletal disease, or patient is like a very poor, who's not a compliant to the test. He doesn't want to do the test properly. So there are people who will not be able to put in a good effort. So all these things will decrease this VO2 via watt relationship. You won't be able to reach the VO2 max. And obviously this entire slope will going very slow, where you have more and more work done, but the VO2 does not increase as proportionately it should do. And this slope will become more and more shallow. So what it means is that when you see the VO2, that it is abnormal, it can only tell you that something is wrong. What is wrong needs further analysis. So you are all correct that VO2 uptake is what we are looking at, because this is a primary parameter which is going to tell us whether this person is normal or it is abnormal. So if it is normal, there is no exercise limitation at all. But if it is abnormal, then you need to find out what is the limiting factor, which will be seen by the other parameters, not by the pure VO2. So I think now what we have understood is that VO2 is actually a overall efficiency of the entire system of the exercise testing. Now, as you start doing the exercise, your VO2 starts increasing, and finally it reaches where, you know, it cannot increase any further. That's the time when you stop your test. So if you have reached the predicted VO2 max, then it is reported as VO2 max. But suppose if the person stops the exercise much below that, then he has not reached the VO2 max, and we call it VO2 peak. So when we see that the VO2 peak is lower than VO2 max, so that means the person has not been able to perform the exercise test to the maximum, and hence the exercise capacity is limited, and we need to analyze that what led to decrease in exercise capacity in that individual. So you can see that these are I told you the slopes. You can see that this is a normal slope. This is an active person. More sedentary you become, it gets shifted. With a disease, it becomes more and more shallow. And as the disease advanced, this slope keeps on shifting towards the baseline, which shows that you keep on doing the exercise, the VO2 and the VO2 and the work rate do not match with each other. So what all can go wrong with the VO2? So we have seen that VO2 is a global index. It is a global index of the exercise performance. It includes everything. So it will be like dependent on the ventilatory parameters and the lungs. It will be dependent upon the cardiac parameters, the heart, and finally the circulatory and the muscular parameters, which are the last parameters from where the oxygen has to diffuse into the muscle, into the mitochondria, where it is going to be utilized to break down the glucose to get the ATPs. So from air, oxygen to the mitochondria, the entire thing is dependent on the VO2. So anywhere, any chain getting wrong will ultimately lead to decrease in VO2. So that's why I said VO2 is a global index. It just tells us if everything is fine, it's normal. If anything is abnormal, it is abnormal, but it won't pinpoint that this is the lungs, this is the heart, this is the circulation, this is the muscle, or maybe even the mitochondria level. So all those individual patterns of those which needs to be seen is the exercise testing. So you can see in this picture that where the oxygen is being taken by the lungs, if they are not taking the enough oxygen and passing it on to the onto the circulatory system into the heart, then there is a ventilatory limitation. When the heart is not able to take this oxygen across into the circulation, then it is a cardiac limitation. When the circulation is not able to take it, then we call it circulatory limitation, which could be related to the vessels. And finally, when it enters into the muscle, if the muscles are not able to utilize it, like myopathies, it is called muscular limitation. And finally, when it is a metabolism which is happening in the muscle in the form of mitochondria, if that is getting abnormal or if that is not able to utilize the oxygen properly, that is called as mitochondrial dysfunction. That is basically a metabolic limitation. So a cardiopulmonary exercise test, which is primarily looking at VO2 max, is actually can give us the results in which the VO2 max does not match with the VO2 peak of an individual. So he is not able to achieve the VO2 max. He stops short of that. And it could have a limitation because of lungs, which is called ventilatory, cardiac, which is cardiac limitation, heart. It can be circulatory system, this is circulatory limitation, and it can be muscular limitation or a metabolic limitation. So these are all to be deciphered in the cardiopulmonary exercise testing. So first look at what happens to the ventilation. And we've come to the question number 8, and over to you, Indranil.
Okay. So the next question, another very important question. What is the characteristic of ventilation, that is the lungs related, causing limitation in exercise capacity? Is it the exercise-induced hypoxia? Is it no breathing reserve, or the chest tightness, or decrease in dead space ventilation? So another, in fact, in that way, easy question. And ultimately 100% have answered no breathing reserve.
I think people are already trained. They don't need me actually.
100%. I'm really 100% of them
already trained actually. I'm very impressed. I would really like to know that who all are participating in polling today, because they are doing very well actually.
So, yeah. Yes, the really dedicated people really
very dedicated for the program and the seminar, and I'm sure that it gives immense pleasure to Indranil and me that we are there to
really. And this at least help us to people so that they don't run away from this CPET machine. Yeah. Near people at least.
I think that's what my entire idea is, that at the end of it, they will say, okay, we'll go and try and see what happens and try to sort out the things.
So it's really, Deepak, if you see, we have really a lot of undiagnosed exercise intolerance, which we really cannot find out even through the 6-minute walk test. The one which is really easier to do, and we do it in our clinic, is the 6-minute walk test. But again, the 6-minute walk test is nothing absolute in it. And this CPET, its implication, where we should use it. Once we use it, then we can understand the real importance of it.
So if the person comes to you and say, I'm dyspneic, and your job is to find out whether he is dyspneic for what, that's the job is basically. And it's not only that respiratory system, it could be your cardiac system. As we have all discussed, 4 equal components or 3 gears of Wassermann could be at wrong. So if that's the job to do it. Most of the times what happens, even if the PFT comes out to be little abnormal, we try to put everything on that this exercise capacity is limited because FEV1 is like maybe like 74%. That may not be the thing. You need to see how much is that exercise capacity limitation, and maybe it doesn't actually match with it. Patient may have a cardiac factors associated with it. So, or maybe patients, very importantly, our respiratory patients are poorly conditioned. Their muscular factors, muscular weakness is so important that actually that is contributing to more dyspnea than their lungs. So we need to actually find out and tease out that what is causing dyspnea in this individual.
So Deepak, what used to happen in the past days is this distinct patient, as the heart rules over the lungs, used to visit a cardiologist. They used to do a echo. Finding the echo to be normal, they used to write no cardiological cause and send to the pulmonologist. And invariably, some of these spirometry abnormalities will be there, and he's put on inhaled medication to treat the dyspnea, and that's all. That's the way that the people are being treated in most of the cases.
We get away with almost 80% of patients in that way, but I think 20% get really stuck where there's no response at all, because that was not at fault. The organ at fault for the exercise limitation was not the correct one. So moving on, that looking at ventilation in exercise, you can see that that we are starting increasing ventilation by more and more exercise. It keeps on increasing. And as I said, the mere thought of starting an exercise increases the ventilation. So some amount of tidal volume increases, and then little bit of respiratory rate increases, and then it starts with an exercise, and then it reaches the maximum. So ventilatory changes are, what we do primarily in this 6-minute walk test is a sub-maximal exercise test. That's not an exercise test to the limitation. And maximal exercise is actually done only in the CPETs. That's the difference between 6-minute walk test, which is also an exercise test, with a cardiopulmonary exercise test, because many people will be able to perform a 6-minute walk test fairly good enough, because this is a test which is performed at the patient's own sweet will. You don't force them to do it maximum. And maximal exercise test is a cardiopulmonary exercise test. And what happens when you start doing the exercises, you keep increasing your minute ventilation. And at one point of time, as I told you, which is about 70% of the vital capacity, when the tidal volume has reached and the respiratory rate around 50, you stop the exercise, because the lungs can't perform invariably. At that point of time, the oxygen supply is so much that some other system, which is mostly, as I told you, the cardiac system, will fail, that it will not be able to do it more, because training is less in the patient, or even the muscular factors which can be trained also be responsible. So at that point of time, when the exercise stops in a normal person, you can see almost about 20% or 30% of the breathing reserve is still left behind. What is this breathing reserve? Breathing reserve is actually the maximum voluntary ventilation which can be achieved by the patient, with minus the maximum ventilation which patient has actually achieved. And we know that normally we expect about 20 to 30%, and if it is less than 15%, that means that the patient, even if he would have tried to do more exercise, couldn't have done it, because there was no sufficient breathing reserve left for him. They are typically ventilatory limited patients, the respiratory limited patients. So they will stop the exercise because they cannot increase the ventilation any further, because there is no breathing reserve left. So you can see in this picture, it clearly tells you, after keep doing the exercise, at the point when you stop the exercise, there is a huge amount of still breathing reserve which is left. So you calculate the FEV1 by the MVV by the FEV1 criteria. You just multiply it with 35 or 40, whatever you take in your labs, and that is the maximum voluntary ventilation which patients can achieve. So if the patient is able to already reach the MVV, so that means patient could have never done more exercise. And that happens only in patients with respiratory diseases, where because the FEV1 is low, the MVV will come down. Even if the patient has got a restricted disease, not necessarily obstructed disease, FEV1 will be low. So FEV1, FVC ratios are normal. FVC is low, FEV1 is also low. So if FEV1 is 40%, the MVV is going to come down. And if the patient is able to reach up to that, so that shows that there will be no reserve left for the patient to carry on. And that's typically what we see in ventilatory limitation. And this is how you can see that the MVV line goes down, and patient has already achieved that MVV line. So there is, otherwise in a normal person, the MVV line was supposed to be here, and you were supposing to stop here with a lot of breathing reserve left. So that means if you wanted to do more exercise, your lungs would have said, okay, I'm ready to help you out. But in this situation, in patients who have got a chronic respiratory disease, you have already encroached upon that the area which is between the MVV and where you have reached. So that means even if you want, the lungs would say, sorry, we can't do anything more for that. So exercise couldn't be sustained because of ventilatory limitation. So you look for the breathing reserve there. So this is again the picture which is trying to show you the same thing, that in normal people, you're supposed to have a significant breathing reserve. But if you have a disease like COPD, you can see that the MBB line comes down and the breathing reserve left is very little. You can see that it is less than 10% or something in comparison to 20 to 30%, which is in normal people. So this is trying to tell you that ventilatory limitation, when it happens, the VO2 is less, but you find that there was no breathing reserve left. So patient couldn't have carried on the exercise because of his lungs, which are the limiting factor for the exercise testing. So also, when we see that, with the exercise, the ventilation increases. So ventilation increases very rapidly in comparison to normal people in patients who have got respiratory disease. So it is very steep curve rather than shallow curves, which we saw with a watt and our oxygen relationship in patients who are unhealthy and are limited in their exercise capacity by any of the systems going abnormal. Here we're talking about the ventilatory system, where we are seeing the lungs. So the ventilation quickly increases and then reaches the maximum from where it cannot increase further. So that's the pattern which you can get. So what all can go wrong in this ventilation? There can be increase in dead space. So as I told you, normally the dead space should decrease. So if it increases, it can cause ventilatory limitation. Hypoxia, hypercapnia can cause. Early onset of metabolic acidosis can happen. More carbon dioxide production can happen. And then there are some other non-metabolic sources which can lead to exercise limitation. So this is what we were talking about, dead space. You can see that we conventionally call dead space VD over VT. That is the dead space ventilation divided by the total ventilation. Normally it is about 30 to 40%. You can see that it is here. And as you start exercising, it starts falling down. So typically the values go below 30% as you start exercising. So the VD-VT ratio as you start exercising should decrease. And if it does not decrease, that means there is a problem in the respiratory system related to ventilation perfusion mismatch, imperfect ventilation, imperfect matching with the perfusion, and these all abnormalities will become much more prominent after the exercise, so that the VD-VT ratio, which is the dead space ventilation, should doesn't decrease, which it is expected to decrease with the exercise. So if we look at the ventilatory limitation, you can see that besides the breathing reserve being not there, you will also see the pattern where you can see that the curve between the V over VCO2, in fact, it just shifts up. VD-VT ratio curve, instead of going down, also remains above. So these are the situations which these two curves, which is VD-VT curve or the ventilatory equivalent of carbon dioxide, because again the carbon dioxide is produced too fast in them, and that also leads to increase in this curve. You can see that the curve is shifted upwards, and it happens in patients who have got hyperventilation or increase in VD-VT. However, the increase in dead space is not only because of COPD, ILD, but also in patients with pulmonary hypertension and congestive cardiac failure. What happens to PO2 in exercise? So you can see that when you start doing exercises, the venous PO2 decreases, which is primarily because more oxygen is being extracted by the muscle. And hence, we may notice that some amount of more oxygen is going in, and ultimately leading to some amount of fall in oxygen. So normally up to 2% can fall with the exercise, but very significant fall if it occurs, it indicates the gas exchange abnormality. And you can see that the alveolar oxygen actually increases, and it corresponds to increase in PaO2. So PaO2 increases, the PaO2 increases, but saturation may fall, and that is primarily because there is more extraction by the muscle. But however, it cannot go beyond the 2%. So again, we are looking at what is happening to these patients when there is a increase in exercise with increase in exercise, there is fall in PaO2. And this is again, it is trying to show us that either there is a less ventilation or mismatch or shunting or even diffuse limitation. So by and large, anything going into the lungs can cause fall in PaO2 with exercise and increase in PCO2 with exercise also. So this is primarily looking at the ventilatory limitation beyond what we said in the breathing reserve. So we have other graphs which needs to be checked on when we are looking at ventilatory limitation to exercise. Then lastly about the AA gradient. So there is going to be more extraction. So if you see that what happens is that with exercise, there is what we can see that the gradient is increasing. You can see that. So there is clearly the gradient which is at start increases with the exercise. And normal is about 5 to 25. It increases with age also. And it's not affected by obesity, hypoventilation, or even high altitude. And it is again a good parameter to look for gas exchange abnormality. That brings us to question number 9, and over to you, Indranil.
So again, another very tricky in that way. Can spirometry during exercise predict cause of dyspnea on exertion? Your answer may be either yes or no, or at least be honest that I don't know. So the result as shown is 67% of them are telling no, it does not show, the spirometry cannot predict cause of dyspnea. And okay, 33% tells that yes,
Okay.
So in fact, there cannot be a right in that way, but still.
There's no right or wrong answer, but obviously what we're trying to emphasize is that the dyspnea due to ventilatory limitation cannot be only because of the respiratory mechanics or increase in ventilation. There are multiple causes for it. So the important thing which happens is a dynamic hyperinflation. And dynamic hyperinflation, the moment you start doing the exercise, you will notice that the end expiratory lung volumes keeps on increasing, and ultimately it eats away the inspiratory capacity of the individual, and the patient cannot carry on with the exercise. So this dynamic hyperinflation which occurs during exercise cannot be predicted at rest. So even if the patients may have a spirometry which is not grossly abnormal, they may be dynamically hyperinflated, and the moment they start walking, they will notice that they will not be able to do it. You can see that in a normal person, the end expiratory lung volume is actually supposed to fall so that you can increase your tidal volume to huge amounts and you are able to do the exercise. But in patients who are dynamically hyperinflated, this end expiratory lung volumes keeps on increasing so that the tidal volume cannot increase at all. You can see that the tidal volumes are not increased to an extent where the patient can do more exercise. So once that is not done, then obviously the person will feel dyspneic. And that is why this dynamic lung hyperinflation cannot be predicted on spirometry. This can be only when they are put to exercise. So now when we do the exercise testing, it has also got a ergospirometry, what is called as that spirometry which is dynamic at 2 points of time when you start the exercise, during the exercise, and after the exercise. So what happens is, you can see in a normal person, you keep on doing exercise, you increase on your tidal volumes, increase on tidal volume, you can see. Now you cannot go beyond this. This is where we have reached almost about 70 to 75% of your vital capacity. So at that point of time, it is still within the expiratory loop of this the flow volume curve, which is showing us that it is not crossing it. It is still within it, so it can carry on with the exercise. But those patients who are dynamically hyperinflated, now they need to increase their tidal volume, and this tidal volume curves you can see are crossing into the expiratory limitation part of the curve. This is the expiratory curve, flow volume curve, and it is encroaching on it. So what is going to happen? So these tidal volumes we are going and hitting at the expiratory limitation part and will not be able to go beyond that, and ultimately lead to the development of dyspnea for the patient, which can be actually seen when we do the dynamic spirometry during the exercise testing itself. So now the exercise testing, not only is looking at the ventilatory parameters, but they are also looking at the respiratory mechanics and particularly dynamic hyperinflation, because it is trying to tell you, you can see this picture, it is trying to tell you that the dynamic hyperinflation, which is shifting of this tidal volume curve up and up, it is happening successively with more and more exercise. And finally, you can see it is at this level that it has almost reached the total lung capacity. So obviously, it is going to be at the point where the exercise cannot be done more, because it is already getting limited by reaching the maximum. And they are not been able to increase so much as you can see a normal person. You can see the tidal volume curve, it is so huge. So that means there is so much of ventilation which is going on. And in comparison to C, you can see that these curves almost look like 50% of what the normal is. So in the bottom also, you can see that the expiratory end lung volume is something which is constantly shifting more and more in comparison to normal person, where it decreases actually with the exercise. So that's one of the pathophysiological mechanism of dyspnea on exertion in even patients of obstructive airway disease, which is very beautifully demonstrated that this is happening on an ergospirometry, which is doing spirometry during the exercise procedure also. And this picture again suggests you the same thing, that this is how normally the tidal volume keeps on recruiting till the time it reaches the large amount of vital capacity. But once it starts crossing, it is going to be limited to that. Then we move on to the second part, which is the cardiac one. So we move on to question 10.
So for this, we have to go back to the definition of cardiac output, definitely. So to improve cardiac output during exercise, minimum increase is seen. We have to know minimum increase. Is it the heart rate, the stroke volume, the AV difference, or the blood flow? So the results are, it's 50% are telling it's the stroke volume, 50% is AV difference.
Okay, so at least 50% are correct, basically.
And that's the reason. But here, with so many good answers, now people don't know. So this should go by the definition of the cardiac output.
Indranil, this is cardiology. This is not pulmonology. That's the reason.
So they forgot what is the definition of cardiac output.
Yeah. So now we have understood. You can see that the stroke volume and heart rate increase. If they don't increase well, then you will not be able to perform any exercise. Stroke volume goes to many times with that. We have already seen. It is the AV difference which is fixed. How much of oxygen can be extracted from oxygenated hemoglobin? That's fixed. You can't go beyond that. So AV difference has got a very small parameter where it can increase, while the other ones hugely. Blood flow increases hugely. The stroke volume increases, and of course we know heart rate increases. Everybody knows. So these are the charts which are trying to tell you what happens within exercise in such situations. So you can see that the cardiac output is increasing successively as the exercise goes on. You can see the heart rate increases, and of course you can see with the training your heart rate will be able to achieve much more. It will be able to increase the uptake much more. That is what the training effect is. And then when you look at the stroke volume, you can see that the stroke volume increases and the stroke volume decreases only in disease conditions. So if the stroke volume doesn't increase, obviously there will be no situation where it will be decreased actually, but if it decreases, it can happen in heart failure patients. But obviously the increase will not be the appropriate in patients in whom there is a cardiac cause for limitation. So this is just to tell you that how much the muscle flow will increase. So huge amount of muscle flow has to increase. So it has to be accommodated by increased blood flow to the muscle. And that we have already discussed will happen by decrease in peripheral vascular resistance and increase in the systolic pressure, which are going to take the blood to the muscle. But despite so much of blood flow, the pulmonary vasculature pressures do not increase. And that is because during exercise, there is opening up and recruitment, both the distension as well as recruitment of pulmonary vasculature, which tries to accommodate more and more blood flow into the pulmonary circulation, thereby not allowing the pulmonary circulation pressures to increase. Because if these pressures will increase, then again there will be hampering of blood flow to the left side of the heart. So after oxygenator, the blood, as it goes through the pulmonary circulation, it is able to accommodate more and more blood, so that it can carry it on to the heart, and then heart is able to pump it out into the circulatory system. So again, this is the same picture which has come up again, which is trying to tell you, you know, how much the heart rate is increasing. It is reaching almost predicted maximum. And you can see that this is the oxygen pulse. Now, oxygen pulse is a surrogate marker of a stroke volume, which we are going to discuss later on. And it also shows you that how it is increasing over a period of time and doesn't plateau easily. It only reaches almost up to the maximum where it is, from where it cannot go any further, because the limiting factor will be at that point of time, because it is VO2 over heart rate, it will be the heart rate which will not allow it to go any further. How much is the expected heart rate which an individual patient should be able to exercise? We take a quick formula, 220 minus age. It is useful, but it overestimates the heart rate maximum for sedentary men and women. And that's very important point, because most of the times you can see that when the cardiologists are doing treadmill, they will stop when you achieve the maximum heart rate. But here we do not stop it. In cardiopulmonary exercise testing, even if you have achieved your target heart rate, if you are still able to do more exercise, you are not limited yet. That means the heart is not limiting factor. Let him go and do the more exercise and try to find out what is limiting the exercise in an individual patient. This situation most commonly happens in athletes, where they are able to outperform and go much beyond their expected heart rates also. So heart rate response can be either steep or shallow. You can see that in this situation, the moment person starts doing exercise, VO2 starts increasing, the heart rate response, which is expected normal, shoots up immediately. This is an abnormal response to the heart rate. Heart rate should not go just like that. So either the patient has got something wrong in the heart, or patient is severely deconditioned, where his heart rate just shoots up like anything. Or is a patient of heart failure, which you can also get a similar response. On the other hand, when the heart rate response is shallow, it slowly keeps on increasing so that the patient is able to perform much more exercise. This is what the training effect and the athletes do show like that. But it also happens in disease states where it is shallow and just stops there. In a shallow where it goes for a long way, that's the athlete, that's the training effect. But if it's shallow and just stops there, again, it will be a condition which is seen in patients who have got a heart failure. So heart rate is also, you are supposed to achieve that target heart rate, which is called heart rate max. But if you stop the exercise before you reach that, then that is the heart rate which you have achieved. And then there is a heart rate reserve left. So normally when you are performing an exercise, there should be hardly any heart rate reserve left, normally less than 15 beats. So you should be able to achieve the heart rate maximum. So that's what we are looking at heart rate here. You can see that heart rate reserve here. You are supposed to reach here, but if you stop here, then obviously there is a significant amount of heart rate reserve left. So if that is left behind, then obviously there is something abnormal in the system, that the patient has a significant heart rate reserve left. So that happens in a cardiovascular system limitation. And that brings us to the next question, and over to you.
This question has already been discussed a bit by Deepak. So here comes the question, that is the heart rate response is blunted, that is the chronological incompetence is seen in which of these conditions? There is heart failure on drugs, inadequate effort, incomplete exercise, and in young adults. So the result is so again a 50-50 answer. 50% heart failure on drugs and 50% inadequate effort.
Okay. The only thing is, you know, the heart rate response, once it starts getting blunted, you know that patient is either a patient who's on beta blockers, or patient has got a heart failure or issues where, you know, it cannot go beyond that. It's blunted response. It is seen that way.
Yes.
Inadequate effort, it won't be blunted. It will go up. In fact, if they put in an inadequate effort, they just go and shoots up like that. So it's okay. I don't think it is wrong in any case. But what we were trying to...
The appropriate one is already been discussed previously by you. Yes.
So chronic chronotropic incompetence is a term which very happily cardiologists are using it, because they will be equating it to drugs, which could be beta blockers, calcium channels. So first thing, when they get a blunt response like this red response, which you see in this case, it's like, you know, a plateau kind of a thing, which is coming very slowly and stops much short of what it should reach. As I told you, it stops much short of what it should be achieved. So you think about beta blockers, calcium channel blockers, patients who have got heart failure, coronary artery disease, even patients who have got triple vessel disease will also show a similar kind of response. But some elderly people will also show this kind of a response. But young people are not supposed to blunted heart response. In fact, they will have almost a super normal response where it will be a more steep response. You may get it with them, or you will get a very good training effect like it is being shown in the blue color out here. And then finally, when they stop the exercise, we start looking at, what rate the heart rate recovers. We know that patients stop the exercise at 220. Okay, let's say he stopped the exercise at 220 heart rate. So at 1 minute, what is his heart rate? That is very important. That is called heart rate recovery. So normally people are supposed to drop in their heart rates by 15 to 20 per minute. So if he stops it at 220, within 1 minute, it should come to 200 or less than that. But if it sustains to 210, so only the drop of 10, that is very abnormal. So that's what we were discussing about. That the slow heart rate recovery actually indicates either the patient is deconditioned or the patient has got issues with the cardiac system, heart failure, and other diseases which leads to decrease in the heart rate recovery. So it can be LV dysfunction, it can be myocardial ischemia, and very importantly, it also predicts the mortality. So the people who have got less than 12 beats per minute of heart rate recovery is actually a poor indicator of survival for 5 years in this group of patients. And I think that answers this question, because
absolutely, you have answered the question in that way. So heart rate recovery is seen indicator of mortality. Yes, no. And even if you don't think that, still do not agree with Deepak, what Deepak said, you can answer, I do not know.
So if it's still not clear, I think you can ask.
Yes. So let me see the answer what people are giving. So yes, now 100% yes, it should be. So 100% answer yes.
So this is what it is called, 1 minute heart rate recovery. So heart rate at peak of exercise and heart rate at 1 minute of stopping the exercise. And if this is less than 12, as I told you, it is an indicator of mortality. You can see in the graphs, it is very importantly that this correlates with the mortality. 5-year survival, you can see that it drops by 68%. So that's why that just finishing the exercise is not everything. We in fact take the heart rate recovery at 1 minute and we take it at 2 minutes, then only we let the patient cool down. And that brings us to question number 13.
So yes. So again, coming to stroke volume, the stroke volume response to exercise is variable with respiration, plateau with increasing exercise, no significant reigning effect. Female have higher stroke volume.
So I think it was training effect. T is been
training effect. So no significant training effect. So again the answer. So again, most of them, 75% has answered that plateau with increasing exercise, and only 25% variable with respiration.
So I think there were two answers correct here. So people have picked up correct answers. So this is the stroke volume. So this is the stroke volume curve with increased exercise capacity. You can see that it goes on and on and on, and finally at the late stage it will plateau down. We discussed that beyond a limit you cannot increase it, and generally it is 40 to 60% where it happens. And you can see that the stroke volume is increased in untrained individual even at rest, and during exercise it can increase significantly. Females have smaller stroke volumes, and it will increase in intensity as the exercise goes on until exhaustion. But at that point of time, it can plateau actually. That's the only time it can plateau, when the patient says, I am exhausted. That means the stroke volume is also exhausted. He couldn't have carried on. That's what I told you. A normal person will stop the exercise because now that stroke volume cannot carry on. His lungs would have done it, but his muscles would have still got it, but the stroke volume is not increasing, so it's not taking more oxygen to the muscle. So, and the muscle doesn't get oxygen, will not be able to perform the exercise, and he stops the exercise. That's how, what is the normal response of exercise is there, and you all have understood it very well. And there are interactions which happen during inspiration and expiration. You can see that the right side during inspiration, the right side of the heart it increases the preload, it increases the afterload, and decreases the LV load, and ultimately increases the LV afterload, which is causing fall in the stroke volume. And during expiration, the reverse will happen and there will be increase in the stroke volume. So normally the cardiopulmonary interaction changes between inspiration to expiration, with fall in stroke volume during inspiration and increase in stroke volume in expiration. And that brings us to the question number 14.
So again, rather simple in that way. After those questions, so stroke volume is calculated in CPET invasively by PA catheter, non-invasively by the fixed principle. If you think that it cannot be estimated by CPET, you can answer this, or really, if you don't think that I don't know, you can answer it. So coming to answer, so non-invisibly by fixed principle is what all of them has answered.
Very correct. So I think people would have by now seen in the last 2 series which I have done that I bring physics always.
Absolutely.
Whether it is a body box or it is a diffusion, there is always a physics laws here. So this is the third law which is coming here, which is a fixed principle. And it is very important because we have seen in the CPAT, we have a VO2. We have a VO2, which is going to determine whether the person is normal or abnormal. And the second important part of it is a stroke volume. And we know that we cannot estimate stroke volume non-invisively by the routine methods which we do. But in this situation, where we are doing CPAT, we are actually getting a surrogate marker of stroke volume by using fixed principle. And that's what the fixed principle is, that VO2 is equal to the cardiac output into the arteriovenous difference. And that is why I was telling you very importantly that arteriovenous difference increases to a limit, and that limit is very small. That factor is very small, so that you can easily use this heart rate into stroke volume is equal to VO2 as a factor to consider what is the stroke volume. So you put a stroke volume into one side, you will find VO2 over heart rate is actually a surrogate marker of stroke volume, where CaO2 over CVO2 is nearly a small figure. And you can imagine when the whole thing is going so big, the change is just about 5%. So from 20 to 15, the 5 grams is the fixed, which you can actually get an extra extraction, maximum extraction. So that is why if this factor is considered as small and constant, the ultimate stroke volume is actually being figured by what is called as VO2 over heart rate ratio, and this is called oxygen pulse. So per liter of oxygen intake, what is the increase in heart rate? That is what is called as oxygen pulse, and it becomes an indirect marker of a stroke volume. So the best part of a cardiopulmonary exercise testing is, without doing invasive measurements, you are getting an idea of what is happening to the stroke volume of an individual by using this fixed principle criteria, which is called VO2 divided by heart rate. So there is a relationship, and this is the clear relationship which you see. And as I told you, I've already explained this, that the CaVO2, that is the content of oxygen in the arterial and the venous blood, that difference which occurs is approximately maximum about 15 ml. So you know that, and if you use the same factor, you can easily calculate the stroke volume from the oxygen pulse by dividing it by 15 and multiplying it by 100. And that is how we are actually looking at the stroke volume in these patients, primarily by the non-invasive method using fixed principle, where we know VO2 and we also know the heart rate of an individual. And this is the AVO2 difference. You can see that the difference is just a little bit, which is between 5 to 15 ml. So even if you take maximum like 15 ml, which showed you, divide it, it doesn't make much of a difference. So the arterial, the oxygen content is not only by increasing the arterial supply, but also by the increased oxygen extraction that decreases the venous oxygen content. So this, since it is the amount which maximally can be taken out, that is the AV difference, arteriovenous difference in the oxygen of the content of the venous blood, between arterial and venous blood, that's the increased extraction. So we are looking at two things: increased oxygen supply and increased oxygen extraction, which happens at the muscle level. So this is the response which you can see between the stroke volume and the oxygen pulse with the increasing heart rate. You can see that this is this normal, you can see that it ultimately plateaus like the stroke volume, and the curve looks pretty similar to the stroke volume curve. And if the curve shifts and becomes shallow, that means that is a cardiac limitation. That means there is a decreased stroke volume response to increase in cardiac output. The heart, which looks normal at rest, is failing at exercise, and that is what is called as a cardiac limitation. This is the most important factor to look for in cardiac limitation to exercise testing. And that brings us to another question, and over to you, Indranil.
So next question, again, another important one. What is the characteristic of cardiac limitation in exercise capacity? Is it the slow heart rate response, the oxygen pulse plateau, which has already been discussed by Deepak in detail, no heart rate reserve, or is it increase in the blood pressure? So the response is, so again, all 100% answers no heart rate reserve.
Okay, so that's the simplest answer which I would have expected. Obviously no heart rate reserve, but heart rate reserve actually can be left also. So that's not an essential part of it. As I told you, these patients are on drugs and they might not be able to achieve the target heart rate. So it may be left. That is true also. But then it is the stroke volume, which is the most important thing. And it should not plateau like that. So you can see that this is the heart rate curve. Heart rate curve can shift in cardiovascular limitation. You can see, as we have said, and there can be some amount of a heart rate reserve, which you said, but decreased stroke volume is the very important part of the cardiac limitation, which you can see. And you can see that this is the oxygen pulse. So the shallower it is and more plateau it becomes, that is the indication that this is abnormal. So of decrease in cardiac output. That brings us to the blood pressure response. We have already discussed. So I think this chart beautifully shows you as you start exercising. So you have seen, I right from the beginning, the VO2 chart and the W chart, both of them are parallel. So whether you get on this axis VO2 or you get W doesn't make a difference. They are all parallel. So they're similar. So you can see systolic pressure increases, mildly the mean arterial pressure increases, but the diastolic pressure remains the same. That is why the mean arterial pressure increase is much less in comparison to what you get as a systolic pressure increase. So this response, it can lead to a peak systolic blood pressure going up to 200 millimeter during exercise. However, it is higher, even more than that, up to 220, 230 in elderly people or who have got more atherosclerosis. So it can happen that even more than 200 it can go. And it doesn't rise that much if the patients have got LV dysfunction. And that is seen when the BP does not increase more than 120 or the BP falls on exercise. So these are actually the things which tells us that you need to limit your exercise testing. So there is serious cardiovascular LV dysfunction in the patients, that the BP does not go beyond 120 with the exercise going on, or actually the BP falls. And this is a very important factor to be considered when the exercise testing. So that's why you need a non-invasive BP cuff to constantly monitor the blood pressure. And if it doesn't increase or if it decreases, it's an indication to terminate the test. And lastly, coming to the muscular factor, we know that there are two types of muscle: type 1 muscle, type 2 muscle, and type 2 muscle is A and B type. And type 2 is a slow twitch muscle. It is a red muscle. So it is a fatigue resistant muscle. So when you need to exercise, you need a fatigue resistant muscle. So you can see this graph which is trying to tell you constant activity. So if you need to walk, you need a fatigue resistant muscle. If you need to exercise, you need to have a fatigue resistant muscle. But if you have to do a brief exercise, then you need this white muscle, which is a fast twitch type, which leads to an immediate activity. So if you want to carry weights, you are looking at your fast twitch muscle. So if you are doing an exercise, you have a red twitch muscle or a slow twitch muscle. So these two different type of muscle activities are basically to look at different type of activities, and they utilize the glucose in a different manner altogether. So you can see that the white or the fast twitch muscle uses the glucose anaerobically, while the red one utilizes is aerobically. And aerobic metabolism, one molecule of glucose will give you 36 ATPs. So I think we need to revise our Krebs cycle again. And when we talk about the anaerobic metabolism, one glucose molecule gives only 2 ATPs and leads to 2 molecules of lactic acid. So that is why I told you that it's a very work inefficient when we talk about anaerobic metabolism. So you can see that the muscle activity, as the work rate increases of the type 1 muscle, it goes on and on. That is a fatigue resistant muscle. And then this one will be quickly utilizing the energy and immediately reaching the chute, but then it will wear out with the incremental exercise. And that brings us to question 16.
Practically, we are on the end of our question series again. So here comes the muscular limitations. So what is seen typically in muscular limitation on exercise? Is it the low ventilation, low cardiac output, early AT, or in fact, if you're honest, you don't know and then answer it? So again, a 50-50 answer. It's 50% have answered it's the low cardiac output, and a 50% have voted on early AT.
So I think, low cardiac output, if there's a muscle which is limiting factor, the low cardiac output will not be the factor.
Yeah. Yes.
Low cardiac output is an indication of cardiac limitation. Low ventilation is actually an indication of ventilatory limitation. And early AT is a very important indication that the muscle is switching from aerobic to anaerobic metabolism very fast. So it can happen in cardiac also, because the heart is not able to supply the oxygen. Less oxygen in the muscle shifts from the oxidative to anaerobic metabolism, from aerobic to anaerobic metabolism. But muscular factor per se, like if the muscle is, suppose there is atrophy of the muscle, there is a muscle poor performance of the muscle. So these muscle will not be able to sustain the oxidative metabolism and will shift to anaerobic metabolism. And that will lead to early onset of anaerobic threshold. That's what we are going to talk about here. You can see that this is the anaerobic threshold. What happens at anaerobic threshold? More oxygen going in, but then much more carbon dioxide producing. So we are able to identify this by looking at it. You can see the chart of VO2 over VCO2. This is the chart which tries to show, for oxygen, for the amount of oxygen which goes in, the amount of carbon dioxide comes out is equal. And it is maintaining this linear relationship. But at the level where it switches, where more oxygen is used and where the oxygen is being used more and more, but much more carbon dioxide is being produced because of anaerobic metabolism, now you can see that this becomes more steep. So there is a sudden change here which is called anaerobic threshold. So the more it shifts to a lower part, the more problems are lying with the muscles which are responsible for the limitation. Because after the onset of anaerobic threshold, person cannot actually exercise any more, because the dyspnea will be primarily produced by more and more lactic acid, which is like the substances which are producing sensation of dyspnea in an individual. So the early onset of anaerobic threshold will lead to early termination of exercise, and it will show that it is primarily looking at the muscular factors which are there. So it can be in obese, it can be decreased in different types of fibers, or it will be in myopathies, various kind of myopathies, and even low body weight also can lead to this. But as I said, that if there is less oxygen reaching the muscle, like cardiac limitation, that can also lead to early onset of anaerobic threshold. So that's also possible there. But deconditioning is also very important part. And that is why what I was trying to tell you is in the metabolic factors, perception of this dyspnea is because of the buildup of various metabolites. So there is a increased hydrogen, there is also lactic acid and other things which are causing more acidotic. So in that situation, you will find that the dyspnea will land up because of that. And this is what it is, the chart trying to show you, that initially in the exercise, when there is aerobic metabolism, there is no increase in blood lactate levels. But once the switch has happened from aerobic to anaerobic metabolism, suddenly you can see in the blood as well as muscle, the lactate levels go. So initially more lactate in the muscle and finally flows into the blood, and the blood lactate also starts rising, and both lactate in the muscle as well as in the blood increases the perception of dyspnea, and ultimately the exercise will be terminated there. So this is what the exercise, cardiopulmonary exercise testing is, that you need to do the test till the patient suffers. That is the suffering is because of the exhaustion. And that point of time, you need to find out which organ led to the betrayal in this patient that he could not perform the exercise. Was it lungs at fault? Was it heart at fault? Or was it muscle at fault? And we have discussed all the parameters, ventilatory parameters to look for ventilatory limitation, cardiac parameters for cardiac limitation, and muscular factors for the muscular limitation. And sometimes it is a pattern of all three which is used together, which we are going to see in this kind of a setup. You can see that there can be so many factors in the limitation. And now you can see this Wassermann gears. And if they are working in a perfect unison fashion, then they will be able to produce a good cardiopulmonary exercise response. But any one of them going haywire can lead to decrease in exercise capacity, which will be manifested at decrease in VO2. So we fall in VO2 is an indicator that there is a decrease in exercise capacity, and you start looking at it. Lungs, it can be lung diseases. You can see the ventilation. Cardiac and pulmonary circulation, you can see the cardiac factors. Multiple cardiac factors have been mentioned, as well as circulatory factors, hypertension, pulmonary thromboembolism, vasculitis, pulmonary hypertension, all can be. And finally, at the level of the muscle, obesity or less blood supply or mitochondrial myopathies, or there are diseases which are predominantly like poor conditioning of the muscle, deconditioning, no exercise, sedentary individuals, it can be again a limiting factor there. So you can see all these together have to be analyzed in this cardiopulmonary exercise testing. And when a person says, stop, I can't do any exercise, you need to identify from these gears, which gear was at fault that didn't allow him to go smoothly into the exercise testing. So to bring this end of the basics lecture on CPET, because in the next one, what we are going to discuss is the equipment, the protocol, and when you start doing the test, there are various panels which are made. They are called respiratory panels, cardiac panels, metabolic panels, in which you will be able to see all these responses, that which response is going on wrong, and ultimately infer from that which organ system is at fault in an individual patient who's exercise limited and is complaining of dyspnea. So that brings us to the last question. And I think, Halder, this is a question which is like, I do not know what people
again, people should be honest with it so that you can proceed with the next presentation in that way. So I think CPT is still confusing, too difficult for me. I think I've understood the basics, need to learn more. And if they tell that need to learn more, practically things will be easier. So be honest to it, and the results are 70% of them things that I have understood the basics, and 30% are telling need to learn more. So
I think
really the response is very good.
Yes.
The thing is that how can you make such a difficult topic discussing the basic physiology of it in such a lucid manner? It's really hats off to you, Deepak. In a way, we have a lot of questions to be answered, and we have 20 minutes or so left. But still, yes, CPT is being used in a wide spectrum of clinical evaluation for undiagnosed exercise, this intolerance, and for objective determination of the functional capacity or impairment. It's true. So just a few things before we answer the questions asked by different attendees. So what I'm seeing your picture there, you have a lot of young people in your team. That's the thing. That's the real enthusiasm you have. So in any way, Deepak, what is the real hindrance in why we people are not really interested in such an important thing, knowing fully well that a lot of undiagnosed exercise intolerance? Because if you see every one patient of 10 patients will be coming with exercise intolerance, and we either from a pulmonologist perspective we diagnose them, or as a bulkers, we do them as obstructive lung disease. The cardiologists will dump them as ischemic lung disease and treat them with anti-ischemic drugs. We pulmonologists will be treating them as bronchodilators and inhaled corticosteroid. But why is the hindrance? Why we are not utilizing that important test? One definitely is lack of knowledge, probably the cost, but what according to you should be, and what the younger generations should do, come forward to utilize this test?
I think, Indranil, you have very rightly pointed out, one is that there is a lot of aura around this test that perhaps this is a very difficult kind of a test. And if you do it, interpretation is going to be also very difficult. So I think because there is no automatic interpretation which comes, people would be happy to see the spirometric reports which come out automatically, but there is no algorithm made for this that you can do. You need to make the algorithm yourself. You need to understand what is going on with the patient, and then it is your patient. You will be able to decide what's gone wrong there. So I think little complications are around because there are so many parameters, and particularly relating to cardiology. So that is why we are not using it much. But I think the issue is that if you have any patient who's got a dyspnea of unknown origin, I think that is the key indication for which most of the patients are coming to you. So you are doing lung function test, and if your lung function test data does not satisfy you, you are nowhere actually. So I think that is the next point that we do, that instead of 6-minute walk test in them, we'll straight away in those patients where we need to find out the dyspnea of unknown origin, we like to find out which is the organ which is limiting this patient from doing what he needs to do, and accordingly you advise them. And that is a very important point.
Deepak, just think of an hypothetical case. A 56 years male comes to you, a smoker comes to you, who has been telling you that he is dyspneic, has exercise intolerance, having cough, and has multiple comorbidities, diabetes, ischemic heart disease, visited a cardiologist number of times, having an echo, say 1 year back, an echo with an ejection fraction of say 62%, and then a spirometry which shows obstructive lung disease. What are the sequence of tests? When you will place a DLCO, when you will place a body box in this, and when you will place this CPET in this patient? So how is the sequence, and when should you place these tests? Or a right typical patients whom you will do a CPET right in the beginning before going for a body box or a DLCO?
I think it's a very wonderful question, Indranil, and very difficult also, because the issue is patient already has comorbidities, and so many of them, he's already a cardiac patient, and many a times that there will still be some underlying cardiac issues in those cases. So in such situation, when we're suspecting that it is a COPD, so I will go for everything together: spirometry, body box, and a diffusion study, all three together at least. And if they show significant defects which are which could be contributing to his dyspnea, I would start the treatment and wait for a CPET test. CPET test we start with those patients when they come from a cardiology and they say that, from a cardiac perspective, this patient is perfectly fine. And we find some non-specific ventilatory abnormalities on the lung function test. We will immediately put them onto cardiopulmonary exercise test. Second group of patients are those who have already undergone PTCA or CABGs, and the cardiologist says everything is fine, the dyspnea is respiratory, go ahead and see the doctor. You see that his FEV1 is like 75%, 80%, and this guy is, complaining a lot of dyspnea. So now you need to know that whether it is cardiac, or is it respiratory, or is it muscular because of poor deconditioning of this patient. That patient will be put to CPAT, and many a times we find his cardiac status is not good. We send them back, they will do angiographies again. They many times they will look the patients, and on the basis of that they will say, okay, we will try to see what we can do again for this patient. So many a time we tell them, relook at your patient, because it still seems that the dyspnea is primarily cardiac here and not ventilatory or respiratory from our perspective. So 2-3 indications between cardiac and pulmonologist are always shifting for CPAT, and that's what we do. But from the many a times we get the patients who are cardiacally declared fit and they are dyspneic, and we hardly find any significant respiratory abnormalities in them. So we will definitely like to find pulmonary hypertension is invariably discovered in this test. So they desaturate and they have a cardiac limitation coming up, which is not because of poor ejection fraction, which is not because of coronary artery disease. Ventilatory parameters are not bad, and still patients are not able to do exercise at all. They terminate the test very soon. They get early anaerobic threshold also, because the blood supply to the muscle is inadequate. Quickly the muscle change over from aerobic to anaerobic metabolism, and we discover that this patient has underlying pulmonary hypertension, which is the cause of dyspnea. And otherwise we would have even thought about psychological causes, anxiety causes, poor deconditioning by the look of the patient. But when you make them do, you realize, oh God, this was perhaps a pulmonary hypertension which was causing it. And then you start looking for it and you find finally that this is the cause for it. So these are some of the peculiar situations where we find CPAT being done. Other situations will be like when we are training them on pulmonary rehabilitation, we are trying to find out how effective the response is. We do for that also. Many a times the patients for sarcoidosis, where we want to, delineate that the dyspnea is, because invariably sarcoid patients, they have some abnormality in FVC, FEV1, they will be given steroids. The dyspnea doesn't improve. You do their CPAT, you find either it is a muscular factor or it is a cardiac factor which is just contributing to dyspnea. Many a times sarcoid related pulmonary hypertension is discovered on that. So I think sarcoid patient is a very good group of patients which are all put into cardiopulmonary exercise testing from the pulmonologist perspective. So these are the certain situations where we are jumping to do CPAT early rather than giving the treatment and looking at the response and then seeing, okay, the response is inadequate. Let's do CPAT and see what's going on wrong there.
So it's a more scientific approach in that way where you go and treat patients. So a few questions from the attendees. Okay, a few questions that has been asked is how do you differentiate between cardiac and circulatory limitations? In fact, that we have already discussed a bit in the physiological part of it. Practically, the next session probably we will be discussing a lot on that. But the cardiac and circulatory limitation, how do you distinguish those?
So see, the cardiac is when the cardiac system is not able to cope up, and cardiac job is basically to provide the stroke volume. So if the heart is not able to provide the stroke volume, so that's the cardiac limitation. Circulatory is that it is supposed to adapt to take that stroke volume which is coming to them. So abnormal increases or falls in blood pressures are all circulatory only basically. So in pulmonary circulation, it will be related to hypoxia on exercise. So they will be limited because obviously the blood flow doesn't go from the lungs into the heart because of increase in pulmonary pressures. Pulmonary pressures should not rise so much, but if they are rising because of pulmonary hypertension, the blood flow will decrease, the cardiac output will decrease. So they'll have some amount of cardiac limitation, but there will be a hypoxia on exercise. So once you have a cardiac limitation pattern with hypoxia on exercise, you pick up pulmonary hypertension. So pulmonary circulation is looked up by a combination of criteria. Peripheral circulation is looked up primarily by the blood pressure response which comes with the patients, and sometimes also because of severe atherosclerosis, the blood supply to the muscle is not adequate and early anaerobic threshold sets in. So again, it is not one single factor. We start looking at 2-3 together, the patterns, and once you fuse the patterns, you are able to say, oh, this is actually what is happening. The blood flow is inadequate to the muscle, so comes early anaerobic threshold. The blood pressure response is inadequate, so that means the circulatory system is getting affected. So that is the primary fault. Ultimately, muscle is not getting the blood. That is why the muscle is at fault. But the primary reason why the muscle is not getting blood is because of the circulation, which is not adapting. So if the diastolic pressure goes high, the peripheral resistance doesn't fall, then this is a situation which will not be able to accommodate the blood flow to the muscle, which needs to increase. This tremendous increase which is required for increase in the muscle blood flow. If it doesn't happen, that shows the peripheral vascular resistance and the pressures of the circulatory system are not appropriate. They are at fault.
So Deepak, a few questions again by common questions, that what is the cost of the setup and what is the cost of the test in some private labs? That's their question, because most of the government, it's true that many of the government setups do not have this instrument. So in administrative capacity, they may be justified in asking what is the cost of the setup.
So in fact, very beautifully, I would tell you this, that in 2007, we bought our first CPAT machine. Primarily because we were doing pulmonary rehabilitation, we thought for that reason we will use the machine. But we realized that more than pulmonary rehabilitation, we need it for dyspnea of unknown origin and evaluation of these patients, which is much more helpful for us. So it cost about 15 lakh rupees. That is the cost of this machine. And it really worked us till 2019. So 12 years, maybe 3,000 to 4,000 CPATs done, which is a huge number, I must say. And tremendous experience and tremendous satisfaction which you get when you see that the patient doing the test and after 4 minutes says, I cannot do the test. And you start finding out that instead of a 10-minute test, why did it terminate in 4 minutes? And then you analyze it, what happened, where wrong, and you explain to the patient, and they start working on to improve that, which is a muscular factor very often in these situations. And then you demonstrate them at 3 months that see how much you have improved. Your exercise capacity, how much it has improved. So that's the question. So how much it costs? So we charge 3,500 rupees for the test.
Metro. In metro. So in other places. So again, Deepak, to take up your case for pulmonary rehabilitation, what advantage do you think over the 6-minute walk test versus the CPET? That's a real question which a postgraduate student should really ask.
I think very correctly, this 6-minute walk test, we all understand the variability is a very important factor there. So, you say that if the minimum difference is coming out to be 35 meters more walked, that will give you some kind of a, clue that your rehabilitation was effective, that patient has been able to do more. Because rehabilitation is to translate into increased exercise capacity with less dyspnea. That is the most important thing we want to do as far as the pulmonary rehabilitation is concerned. But when it comes to figures, it is VO2 max. So VO2 max is something, if you have improved 10% VO2 max, it is going to translate into a better exercise capacity. And that reminds me one more situation where we do the CPAT is when the patients are going for thoracic surgery like lung resection. So some of the patients, they have a poor lung reserve. So you need to be above 10 ml of VO2 per minute per kg body weight of that value. So if you cross that value, preferably 14 or something like that, then the patients are very good candidates for a post-operative early recovery and not much post-operative complications. So that is pre-operative evaluation. Again, a CPAT is a thing which we do for all patients undergoing thoracic surgeries.
So in fact, Deepak, what I think is that by doing a CPET in a pulmonary rehabilitation lab, you can definitely tell what type of exercise can be done by those patients in the most scientific way. In fact, the rehabilitation people, they are very trained in that. If the VO2 max is such, so that we can do this type of training exercise of the upper limb, of the lower limb, this type of endurance exercise or other type of exercise that they think of in the most scientific way, which is usually not done in most of the places.
I think you are very correct that we tell people to do exercise, but how much exercise? The importance is that unless an exercise is done at VO2 of 60%, it is not going to improve the exercise capacity. So any exercise is better than no exercise, correct. But exercise which is unless and until targets 60% of VO2 max, it will not translate into an increase in exercise capacity and lessening of dyspnea in that individual. And for that, you are very correct that if you have the value, then you can plan the program of exercise which is hitting that VO2 max of 60% to begin with, and you build up on that later.
So another way that the question has been asked, patient is 65 years, smokers, hypertensive, diabetes, now control, having dyspnea and severe osteoarthritis, both knee. How do you do the CPET? In fact, there are two ways, bicycle ergometer and the treadmill. What is the one that you have in your metro, or the both of them do you have, or the?
Yeah, we have both of them. The issue is I'm going to discuss in the next lecture itself, because bicycle ergometer is actually doing watt by watt. So actually translating into a work is very easy, where you don't have to do any calculation. But when you do it on a treadmill, you have to do METs, and METs have to be translated into workload, and then workload is to be translated into VO2. So it's a little difficult calculations which are required for a treadmill.
But these are all done by the software that you have. These are just in software.
But these all softwares are very friendly on a bicycle. So the only problem is that those patients who have got knee replacements, hip replacements, and the people who have got severe osteoarthritis won't be able to sit on the cycle. There is an issue with them. So you do it on a treadmill, you do it very slowly. But remember one thing, these fragile patients on a treadmill can fall actually. So that's why personally the cycle is much better. And in Indian mind, I think most of the people are very happy to do cycling. So we always used to think, the female patients will not be happy to sit on a cycle. But surprisingly, they are also more happy and steady on a cycle vis-a-vis treadmill, where they need to be little more control over the body actually. And you also need to be very cautious that they don't fall on a treadmill.
Treadmill, again, the railing is what is to be avoided in those people who are doing CPET. So what about your comment on railing in CPET?
It is very difficult because everybody wants to hold the railing and then move onto it. And you can't walk with this thing. So you need to have a free walk on the treadmill. And most of the times, we go by increasing a little incline up to 2.5 or something like that. And we don't go, in a very high speeds for them, because these patients are not able to get in a treadmill very well, basically. And we again find that most of the times, like if we are doing 20 CPATs, one will be on TMT and the rest all will be on the bicycle only.
So again, another common question which has been asked: what are the contraindication and where we should not put a patient on CPET? What are the contraindications? In fact, the main contraindication, relative contraindications are there, and they are absolutely there in the guidelines. If you can repeat them.
It is going to be covered in the next one, basically. I'm going to come to the contraindications in the next one.
Okay.
So all cardiac instability patients will be unwanted patients on the CPAT belt, definitely. Cardiacally unstable patients who have got
myocardial infarction, unstable angina,
cardiac arrhythmias, they will not be the candidates for CPAT.
So again, just to ask you, do you monitor those patients of ILD by a CPET, or by the 6-minute walk test is good enough for these ILD patients?
We generally do 6-minute walk test only for them. The only ILD patients in which we do CPAT routinely are patients of sarcoidosis or some other in which they are better preserved to perform the CPAT tests for the rehabilitation purpose.
So again, another question: do you think that all heart failure patients who have comorbid conditions should be undergoing a CPET or not? All heart failure patients who have other comorbidities.
So in fact, you see, in a heart failure, the biggest predictor of mortality is your CPAT performance. VO2 max is an accurate indicator of your 5-year survival. So that's why it is recommended in many cardiac centers that you should do their CPAT and then aggressively manage these patients.
And in fact, there are a lot of publications in this with heart failure and CPAT, a lot of publications.
In fact, the most robust data on CPAT is in heart failure patients, actually.
Absolutely. So again, another question: a patient who is having a saturation on pulse oximetry less than 92 and cardiac condition is normal as assessed by an echocardiography, a spirometry is normal. Is this patient a right candidate to do a CPAT?
Yes, absolutely.
In fact, ABG should be done in this patient. Ideally, I should tell an ABG should be done. And if the ABG, I don't know. There are other conditions where which you can get a low SpO2. But still, if you can rule out those, CPET should be coming into the armamentarium of investigation that you should do.
So 92% saturation is no problem. If you ask us, we even take patients who are 88%. We even take those patients for the CPAT.
So practically, we have answered most of the questions. How long do it take to do a CPET, and how long? What is the time duration? In fact, we'll be discussing it in the next session. In fact, the next session will be on, and this is basically on the basic physiology, why we do this CPET and all those. So with this, Deepak, we are just finishing in time. So can you just give us a brief take-home message or the bottom line message to the audience so that they can move on for the next session, which will be say in a few days or so? The bottom line message to this.
I think the bottom line message, Indranil, would be that don't be scared, don't get frustrated. It can be made easy. Only thing is that if you see the reports, you will start realizing that there are rules and regulations, and if you follow them, most of the times you are able to narrow down your differential diagnosis to one particular condition. Or maybe there was sometimes maybe 2 causes of dyspnea, and you will be able to beautifully see that both of them are there in an individual patient. So multifactorial causes of dyspnea can also be easily elucidated. Only thing is that it requires a little training on that part, but it is not all that difficult. But what you need to understand is your own physiology. You people have picked up minute ventilation for the lungs, and you have picked up the stroke volume or the oxygen pulse for the heart. We have a PO2, PCO2, which are the gas exchanges. Basically, we are looking at exercise hypoxia, again looking at the diffusion capacity or the diffusion factor of the lungs. So all this, and the factor, which is the anaerobic threshold. So if you have these 4-5 things in your mind, you will be able to do, because we all go around these 4-5 things only. They are the only things which are going to be, only the pattern is going to be different, and you are going to understand that why this pattern is different. Is it the oxygen coming in low? Is it the oxygen transfer which is getting bad? Is it the heart not able to push to circulation, or the circulation not able to give it to the muscle, or muscle even getting oxygen but is not able to utilize it? So I think if you see that cycle and you see how the gears move, it is not difficult to understand. And you, once you start using it, you'll realize how you test
the
it.
more number of tests we do, the more we'll be acquainted with it. Again, it's another if undergraduates, the postgraduate curriculum should change some of their course again, Deepak. What I think so, because once this diffusion has been introduced in the, it's a must for the postgraduate recognition. All the medical colleges have procured this DLCO machine. So if in the postgraduate curriculum or the inspection, they tell that this CPET machine is a compulsory, most of the government medical college will be procuring it. And once they procure it, the postgraduate student will get acquainted and know the importance of the test, how important the test is in differentiating causes of exercise intolerance. That's the only thing. The more we get acquainted with, the more we learn of it. So with this, thank you, Deepak, for your excellent and vivid explanation to this. Thanks everybody to the audience for joining. But the another important thing, please don't forget to give your feedback, valuable feedback. And we hope we will be seeing you again in the next series of advanced lung function, the pulmonary function test workshop. The date probably has been announced, Deepak.
Next Wednesday.
Next Wednesday. So thank you all. Thank you, Deepak. Thanks to all the audience. And after all, I should thank the Indian Chess Society and the PACS India for their initiative to support this such kind of beautiful this webinar or the workshop, as you call. So thank you.
Thank you, Indranil. Thank you. Wonderful being a partner with me today on this very difficult topic. I suppose, I think people said very clearly that it is a difficult topic, but people had read already about it and they went through it very well. And I'm pretty sure when all these principles will be applied onto practice in the next session, they will realize that it looks difficult, but it's not all that difficult. Thank you very much, Indranil. Thanks a lot.
Thank you. Bye
to everyone.
And bye to everyone. Thank you.